Ms Monaghan. There you are. You were over there earlier, weren't you?
No. Good afternoon, my lady. I make this closing statement on behalf of the Department of Health for Northern Ireland, which I'll refer to in the course of my submissions as the Department. And by this closing statement, the Department wishes to confirm that it has carefully listened to and reflected on all of the evidence adduced and the issues that have emerged in the course of these hearing sessions. By these submissions, the Department would also like to address some issues that pertain to its role in the implementation of the vaccine rollout programme in Northern Ireland. We would also like to make some points about the lessons that the Department has learnt and its preparedness for the next pandemic. My lady, it is considered that on a fair analysis that the vaccination programme in Northern Ireland was a success. Some successful factors included the level and extent of preparedness which was in place at the time when the vaccines began to become available, the manner in which the Department was able to overcome logistical and technical problems in order to develop and administer a programme which resulted in the vaccine being made available to everyone who was eligible in line with JCVI advice. The development of the vaccine management system, which has been referred to as the VMS, that accurately recorded all COVID-19 vaccinations which were administered. The fact that the Department ensured that the Northern Ireland programme closely coordinated with the other UK vaccination programmes, which were considered to be important both in terms of vaccine equity and also in terms of public confidence. Finally, my lady, we we considered that the maximisation of access to the vaccination programme, which was delivered from GPs, through HSE trusts and through over 400 community pharmacies throughout Northern Ireland, resulted in a high percentage of the population being vaccinated in an orderly and an efficient manner. Another key aspect of the programme, and one which the Department believed represented a strong outcome, was the fact that the Department ensured that residents in care homes were prioritised and vaccinated in the first tranche of vaccinations, thereby providing protection to some of the most vulnerable in our society. This success, of course, must be viewed in the context wherein the COVID-19 vaccination programme was the largest and most challenging in the history of the Northern Ireland Health Service. Another important aspect, my lady, of the successful rollout of the vaccination programme was the close coordination across the four nations. As my lady no doubt remarked, was clear from the evidence that was given by all four of the senior responsible officers. That close coordination between the SROs meant that Northern Ireland was able to benefit from the experience of others when issues were encountered, and in turn provide insight into how it resolved issues when they arose in Northern Ireland. Of course, my lady, there were naturally challenges in the implementation of such a significant vaccination programme, both in terms of the unprecedented scale and the speed within which it had to be established. The inquiry has heard evidence about the challenges faced throughout the UK, and there were challenges in the vaccination programme that were particular to Northern Ireland. For example, the Department had to consider and address issues arising from the additional regulatory requirements that were imposed by dint of the Northern Ireland Protocol. These additional requirements were relevant both to the authorisation and the access to the vaccines. The Department worked closely with the MHRA to ensure that appropriate measures, such as the use of the temporary authorisations under Regulation 174 of the Human Medicines Regulations 2012, were progressed in order to ensure that Northern Ireland could access the vaccines at the same time as others in the UK. The Department was also obliged to work closely with the Vaccine Management Task Force to ensure that the vaccines that were supplied to Northern Ireland met all regulatory requirements, again arising from the Northern Ireland Protocol. I'd like to say something now, my lady, about the hard-to-reach groups. The Department confirms that it took specific action to address those difficult-to-reach groups in order to promote vaccine equity. These actions included proactive outreach to ethnic minority groups, to socially deprived areas, to isolated occupational groups, to migrant workers, to the disabled, the housebound and those living in our rural communities. In order to improve vaccine uptake, the Department deployed a range of award-winning communications, which included the use of specifically targeted social influencers and trusted voices in its engagement with community groups. My lady, these actions were driven by data that was gleaned from the vaccine management system and also from local intelligence that came through our public health agencies' links with community groups. The ability to communicate and connect with those groups at the appropriate grassroots level was as a result of the PHA having a long-standing and trusted relationship with many of those groups. In terms, of course, then, my lady, of misinformation and its impact on vaccine hesitancy, we would say that the Department confronted the challenges of misinformation and vaccine hesitancy, largely by seeking to understand the challenges of the anti-vax messages and the specific concerns that were particular to Northern Ireland. In addition to engagement with the low uptake groups, we were conscious of the importance of public messaging, and the Department accordingly published Mythbuster, or fact file information, that was delivered through public health campaigns, through its community pharmacies, in its Living Well service. My lady, it should also be noted that Northern Ireland residents were able to, and in fact did, participate in a large number of the COVID trials, some of which included Recovery, Remap Cap, Panoramic and others. Additionally, Northern Ireland recruited well for the Novavax vaccine study. I'd like to say something more about the vaccine management system, which was a considerable undertaking. The Department had realised from the spring of 2020 that if there was going to be a mass vaccination programme, it would need a sophisticated system in order to be able to record accurately all of the vaccinations. Accordingly, from that early stage, steps were taken to investigate how such a system could be developed. As more information regarding the vaccines became available, those steps were put in train. Although the capability of the vaccine management system developed over time, it should be noted that it was operational from the first day of the vaccine programme on the 8th of December 2020. There was clearly a challenge to make sure that the operators were able to confidently use the system and that it effectively interacted with our GPs' IT systems. But all of the elements of this vaccination programme, including trusts, GPs and community pharmacies, had access to the vaccine management system, and the benefits of the receipt of information in such a prompt time were, we considered, significant. The fully operational vaccine management system allowed for accurate and timely access to vaccine uptake data, which in turn allowed areas of low uptake to be identified and targeted actions to be taken. In particular, the introduction of the vaccine management system was a key enabler of our ability to deploy into community pharmacies. It facilitated communication and the prompt updating of medical records following the vaccination. Of course, my lady, Northern Ireland already had existing data recording systems, and it built on and developed from those systems to develop its dashboards and the vaccine management system, both of which were expanded and improved throughout the course of the vaccination programme. It is hoped that these improvements will allow for a more nimble and data-driven approach in any future pandemic. Moreover, being able to communicate in a contemporaneous and transparent way with the Northern Irish public, we felt inspired hope, which in turn led to confidence in the system. My lady, the department's work on vaccine rollout has left a legacy of UK-wide cooperation and a better understanding of the importance of societal efforts at a time of emergency. The department now has a greater insight into potential barriers to the uptake of vaccines and the importance of vaccine equity. There is also a legacy of technological advances, such as the VMS, which is currently used in our other vaccination programmes. Regrettably, my lady, in current programmes, there are continuing challenges with vaccine hesitancy, but important lessons have been learned and work is ongoing to fully understand and address the multiple reasons behind this hesitancy. I'd like also, my lady, to say something about the integrated care system and the impact on the vaccination programme. A key advantage of our integrated care system in Northern Ireland was that it allowed the department to use social care and community resources more effectively, thereby vaccinating those who were housebound or in care homes. A clear advantage was the increased level of coordination with social and healthcare sectors, which contributed to the development of a more efficient and better coordinated approach to the vaccination programme. In the integrated care system, there were demonstrable advantages in the fact that policy colleagues were experienced in working closely together, which meant, in turn, less red tape and fewer organisational boundaries for the smooth processing of work. A practical example of the benefit of the integrated care system was the speed at which the department was able to roll out its vaccinations into care homes by dint of redirecting trust assets, so that by the 8th of January 2021, 90% of care homes had been visited by vaccination teams. My lady, in terms of lessons learned, the department considers that it has improved its understanding of how to deliver successful vaccination programmes as a result of the work that it undertook on this COVID vaccination programme. It considers that it continues to learn from its experience of delivering vaccination programmes more widely, and in evidence, the Deputy Chief Medical Officer referenced the importance of providing the public with a fuller understanding of the steps taken to secure safe vaccinations and the means by which any consequential effects of the vaccine should be put on record and collated. In addition, the department continues to develop its understanding of the behavioural and social science factors which lead to vaccine uptake. It is acknowledged that the success of our vaccination programme was the best form of defence against COVID-19 and was crucially important in ensuring that Northern Ireland could return to a level of normality. The practical lessons learned from how to implement, swiftly and effectively, vaccination programmes will be undoubtedly invaluable in any future pandemic. To conclude, therefore, this module of the inquiry has been focused on vaccine rollout, and it should be emphasised that the successful rollout in Northern Ireland would not have been possible without the contribution and commitment of the staff involved and the response of the citizens of Northern Ireland. The Department believes that this is an appropriate point at which to again express its sincere thanks to everyone involved for their unerring and unselfish commitment. Thank you very much, my lady.
Thank you very much, Ms Manhunt. Mr Thomas.
My lady, the reality is we cannot change history, but we can change the present. And I think that's something very important to remember. Every day is an opportunity to rebuild trust And I think COVID was a huge opportunity to try to rebuild that trust. And now is a big opportunity. Dr. Heidi Larson on the 16th of January at this inquiry. Milady, the evidence presented during this module has revealed undeniable failings that disproportionately impacted ethnic minority communities, including inadequate engagement, systemic inequality and bureaucratic delays. FEMHO submits that these issues are emblematic of the deeper structural inequities that pervade our healthcare system and public health strategies. Addressing these failings is not merely a question of fairness, but a matter of necessity. One of the most glaring takeaways from this module is the lack of a coherent national effort to engage minority ethnic communities during the vaccine rollout. Milady, government witnesses have acknowledged that health disparities and concerns about the uptake were foreseeable. Yet, despite this knowledge, there was no nationally funded, coordinated campaign to address these challenges in real time. Instead, what we had was fragmented, piecemeal efforts characterised by the government's approach, which, as Dame Kate Bingham testified, quote, significantly hindered progress and caused harm to the efforts that were being made across the country by individual groups and organisations. Milady, no one is denying that the task was huge. There was not only historic mistrust, but also mis- and disinformation during the pandemic that were pressing concerns. Organisations like FEMHO stepped up because they wanted to help. Milady, you'll remember Dr. Salman Wakar's mention of the Brandolini, or commonly known as the BS principle, which emphasises the great effort it takes to debunk misinformation in comparison to the relative ease to creating that misinformation. Healthcare workers like Dr. Wakar found themselves having to do more work with less resources in order to tackle that mis- or disinformation and build trust. This fragmented approach was further compounded by the fact that private companies often stepped in where government failed. As Dr. Wakar pointed out, platforms such as Facebook provided funding and support for community engagement work when that should have been a government responsibility. The British Islamic Medical Association launched the Bimba Misbufta series, a campaign led by trusted Muslim healthcare professionals to dispel misinformation and low confidence within the Muslim and ethnic minority communities. This initiative reached vast audiences through social media and grassroots networks and was wisely praised for its cultural sensitivity and community-driven approach. You see, Milady, it's about trust. Trust is the cornerstone of public health. Hard to build, easy to break, and essential to repair. Dr. Wakar, Dr. Larson, and Dame Kate Bingham all underscored the importance of trust in driving vaccine confidence and uptake. You see, building trust requires more than government messaging. It demands meaningful engagement led by trusted community leaders who can bridge the gap between institutions and the people they serve. Practical measures such as ensuring that tools like the yellow card scheme are accessible and available in multiple languages are also critical. Simplifying the reporting systems and tailoring communications to resonate with diverse communities, not just recommendations. They are imperative for building trust. Do you remember the full circle argument? What was clear in Module 4 is the full circle argument broken down by Dr. Larson, which FEMO hopes will resonate with this inquiry. It all starts with the fact that pre-existing health inequalities and historic mistrust are unaddressed, despite them being foreseeable, which in turn means that there is poor engagement with minority ethnic communities in respect of the national vaccine rollout scheme, which then causes poor diversity in clinical trials, low trust in vaccines, and low uptake by the same communities, which means sentiments hardened and there's a general growth in vaccine hesitancy or lack of confidence, which means government then needs to consider policies like the vaccinations as a condition of deployment to drive uptake, which might increase uptake in the short term, but then has a knock-on effect of building and reinforcing distrust, which means coming back full circle that there's an impact in years to come regarding vaccines, trust in government, and perpetuating and worsening health inequalities in our society. This vicious cycle must be broken. Without systemic reform and continuous sustained meaningful engagement, Milady, these issues will reoccur with future public health crises. The issue of diversity in clinical trials. You may have seen me twitching in my seat when this was being raised by various witnesses. Let me explain why one was twitchy. It's important to clarify that outsourcing diversity to countries such as South Africa or Brazil, while providing data on certain ethnic groups, fails to address the unique challenges of mistrust, vaccine hesitancy, and systemic inequities faced by minority ethnic communities in the UK. The government and vaccine companies fundamentally misunderstood the nature of low confidence, treating it as if it was a biological issue. They assumed that providing safety in black populations abroad would automatically translate into trust amongst ethnic minority communities in the UK. However, Milady, vaccine mistrust is not just about biology. It's deeply rooted in historical injustices, systemic racism, and lived experience of unequal treatment in healthcare. The assumption that, well, we tested it on black people in another country, therefore UK ethnic minorities should trust us, is gravely misconceived and tone deaf, because it ignores historical mistrust and structural racism in the UK healthcare, the very reason why many ethnic minorities had low confidence in the first place. Secondly, it assumes that trust in one healthcare system automatically translates into historical trust in another system. That's not how it works. It conflates racial identity with shared experience when racial ethnic minorities in the UK have different social, cultural and historical contexts than in South Africa or Brazil. Milady, can I just come on to, and I've nearly finished, some couple of additional considerations. We've got to avoid the oversimplification of racial and ethnic identities. We've got to realise that while communities of colour globally may have shared experience of racism, the causes and manifestation of mistrust are deeply shaped by their local histories and social systems. All of this did not happen in a vacuum, nor was it a quirk of history. It's real, it's persistent, it must end. Squeamishness around race and racism in our healthcare system has been consistently demonstrated by several witnesses and cannot continue, whether it's a matter of vaccinations as a condition of deployment, clinical trials or data, racism is undeniably a key determinant in outcomes of the experience of Black, Asian and minority ethnic communities. So, milady, let me conclude by saying this. You will remember Health Secretary Mr. Hancock acknowledging the long-standing structural racism within the healthcare system, noting that part of the work was trying to understand what to do with structural inequalities, yet in practice, this recognition did not translate into meaningful action. So to conclude, FEMHO wants an acknowledgement that ethnic minority groups, healthcare workers and community leaders have made immeasurable sacrifices to help the government during the rollout. They have an enormous pride in the fact that, despite racism, they took the approach of being, we're all in this together. Yet, despite that, the government failed to take the invitation seriously, asserting that they did all we could, when ultimately they did not. We know this because the uptake was affected. Diversities in clinical trials was poor. Resentment for the government increased, and as a result, COVID-19 impacted ethnic minority communities at a far greater rate than their counterparts. The paucity of data also meant that negative trends were not being properly monitored by central government. Finally, this. Milady, the failures we've examined here are not simply historical. They are present, they are urgent, they must be addressed. Dr. Wakar rightly said it all goes back to trust. Every day is indeed an opportunity to rebuild trust. Milady, let this inquiry be a catalyst for transformative change, ensuring that trust is not just restored, but earned through meaningful systemic reform. Milady, the time to acknowledge is now. The time for reform is now. The time to act is now. Thank you.
Thank you very much, Mr. Thomas. Very grateful. Mr. Rollout.
Thank you, my lady. I make this closing statement on behalf of the United Kingdom Health Security Agency, or UKHSA, as I'm going to refer to it today. Your ladyship is by now familiar with the role of UKHSA and the circumstances in which it was established. The considerable work that UKHSA is already doing to implement the lessons that are being learned from the pandemic is set out in the statements that we have provided to the inquiry. You have also heard in this module from Professor Harris and from Dr. Ramsey. I do not want to summarise that work today, but rather what I wish to take my time for is to touch on 4 themes with relevance to the future. The first, which has already been alluded to today, is the importance of data preparedness and transparency in responding to future health threats, including pandemics. This is a theme that we have addressed you on in previous modules. But improving the safe collation and sharing of data across the healthcare system to a point where there is a unified approach offers significant opportunity to improve health outcomes. But it must be seen in the context of similar moves in other parts of the public sector. As we have pointed out before, the use of data raises important legal and ethical questions. Further, and with this module in mind, where, as you've just heard, trust is central to combating low vaccine confidence and promoting vaccine uptake, the data systems developed in peacetime must be sufficiently robust to maintain public trust. Consideration must also be given to the potential that relaxing restrictions on data sharing during an emergency could undermine public trust, so actually having a counter effect of increasing vaccine hesitancy and or reducing vaccine uptake. The benefits of sharing data are inevitably contingent on the quality of the underlying data. Recommendations for enhanced data collection are complicated by individuals' reluctance to give personal information, and as has been articulated during this module, a lack of robust national data in relation to certain groups. for example, undocumented migrants, Gypsy, Roma and traveller communities. It is therefore important that information sourced from local networks is not overlooked, because that risks worsening the exclusion of individuals and communities that already struggle to access healthcare services or, simply put, are not registered with a GP. The second theme that we would address you on today concerns the complex question of how to improve vaccine uptake among communities who are already underserved by the healthcare system. Ensuring that vaccine uptake coverage is not only high overall, but high within such communities is essential to an effective elimination strategy. This is not an issue to be left for a pandemic. It is, as Dr. Ramsey put it, an issue for all time, and one which requires a concerted, long-term commitment of time and resources from multiple organisations to lay the foundations for an effective response in a pandemic. UKHSA has an important but defined role to play in addressing barriers to vaccine uptake. In delivering routine immunisation programmes, UKHSA, as PHE did, and that's Public Health England, did before the pandemic, seeks to publish resources that are culturally competent, targeted, available in different languages and media. UKHSA works with NHS England, MHRA and academic partners to deliver the surveillance and evaluation of immunisation programmes, which is critical to vaccine safety and confidence. The public health teams that Public Health England had embedded in the NHS have now been transferred to the NHS, but UKHSA maintains links with that expert network and with the wider public health systems in the NHS and local authorities. However, as Dr. Ramsey pointed out, it must be remembered that vaccination is a medical intervention delivered at specific points in time. Trust is a key factor in addressing barriers to vaccine uptake within underserved communities. And so working closely with trusted organisations over the long term is fundamental to ensuring the success of outreach activities. To avoid a one-size-fits-all approach to addressing barriers to vaccine uptake, there should be a local to national public health response, building on work led by directors of public health and emphasising the importance of those working at the local level who are likely to be more tuned to the specific needs of the communities in their area and can build trust over the long term in partnership with those communities. Finally, we should not forget that low vaccination uptake in underserved communities reflects a broader picture of inequalities across the health system and should not be seen in isolation. There needs to be a whole system approach. If those who are underserved are better able to access high-quality primary care and other services in peacetime, then the likely benefit would be an increase in vaccination uptake. Were this inquiry to highlight the importance of a holistic approach to tackling health inequalities at a local level, with community services being able to offer sustained engagement through trusted workers, then that would be of real value to embedding continuity of care in the longer term. My lady, the third theme that we would address is whether more can be done to ensure that the public is as informed as possible about vaccines. You have received written and oral evidence about the strategies that PHE and now UKHSA have deployed and do deploy to provide accurate information on the benefits and the risks of any vaccination. This includes publishing information on the Gov.uk website and through the NHS, which clearly enjoys a great deal of public trust. All this work ensures informed consent and promotes vaccine confidence. But it is a feature of the pandemic that a great majority of the population, some perhaps for the first time, sought out information about vaccines. They did so in an age where inaccurate information about a vaccine's effectiveness and safety can be so easily spread. And so establishing a single authoritative resource for immunisation, such as a dedicated website accessible to both the public and to healthcare professionals, would play an important role in countering misinformation. Such a resource could, in a very practical way, enhance public awareness of safety signals, facilitate informed consent and sustain vaccine confidence. Recognising that consent is a process, not a one-off event, this resource would complement rather than replace the use of written materials and face-to-face conversations with healthcare practitioners, which should remain an integral resource, particularly for those facing digital exclusion. Finally, my lady, the last theme that we wish to address you on today concerns the potential recommendation which the inquiry has explored of a national vaccines agency, which, as Dame Kate Bingham explained, would sit slightly outside government, have very strong external input, and the independence and authority to be able to report directly to the Prime Minister. It would be envisaged that this agency would have an end-to-end role. In that sense, any such agency would be similar to the Vaccine Task Force. However, while superficially attractive, the proposal prompts obvious questions which are not easy to answer, including, for example, what budget would this new agency need? That's a question that your ladyship put to Dr. Dix a short while ago. It reflects, of course, the premise that the vehicle may be less important than the resource. The VTF's initial funding was over £5 billion. UKHSA currently operates to provide all of its services, including non-infectious disease science and response and global surveillance, within 3% of its original pandemic budget, a figure that, as we've pointed out before, is akin to that allocated to a moderate district hospital. Second, how do you manage conflicts of interest if your external input is short-term secondment from industry, bearing in mind that relationships with industry, if poorly managed, can contribute to vaccine hesitancy? Third, how do you maintain the independence of the JCVI and the MHRA? Fourth, you'll recall Dr. Dix explaining that the ability to focus just on vaccines was a strength of the VTF. Would you therefore need a separate national therapeutics agency, given that a vaccine is not always a certainty? And finally, given that there are no discrete boundaries in clinical and scientific research, would a vaccines agency ultimately lead to the creation of multiple bodies, all essentially doing the same thing? My lady, the VTF was a remarkable success. It was stood up at a time when virtually everything stopped for COVID. The country's good fortune was that the political will to take risks in an emergency meant investment in a wide vaccine platform in response to a single pathogen. Peacetime asks a different question. Namely, are the systems in place capable of addressing multiple different threats, capable of being scaled up, and of being made even more timely in their response? This is the type of system that UKHSA is already working towards and is seeking to maintain for the future. Embedding that system could save lives and protect the economy. In our opening statement, we pointed to 4 capabilities which need to be nurtured for the future. They were sustained research and development, strengthening partnerships between government, industry and academia, the benefit of routine vaccination work, and the importance of surveillance and monitoring. These are perhaps more prosaic than the call for a new agency, but they need to be supported because they reflect the long-term work pre-pandemic which underpinned the VTF. And this is why, for example, UKHSA has improving health outcomes through vaccinations as a strategic priority. It is why it undertakes funded research, often in collaboration with academia and industry partners. And an example is the funding provided by the Coalition of Pandemic Preparedness Innovations, which is an international partnership between public, private and civil organisations for UKHSA to develop a laboratory assay for Mpox, a first step to developing a vaccine. It's why UKHSA continues to develop ongoing relationships with industry. While the Moderna strategic partnership may be the example that's best known to the inquiry, in this module you've heard evidence as to how post-pandemic UKHSA is working with other companies, Valneva and Seqirus being examples. It's why UKHSA has established the Vaccine Development and Evaluation Centre, or VDEC, as it's been referred to, with a remit to support the identification of the most promising vaccine candidates and to provide preclinical and clinical trial testing of vaccines. We note Dr. Dix's view of VDEC, but its relevance as an initiative is because it goes towards strengthening relationships with industry and academia. And finally, the final example I would give is that UKHSA has built a new global surveillance system and is developing a UK priority pathogen tool aligned to and working with the World Health Organization. My ladies, since the pandemic, UKHSA and others have sought to build systems ready to respond to a future threat. In considering the recommendation to establish a national vaccine agency, the inquiry will want to assess the impact that such a step would have on the work that has been done and which is planned. Would such a reset undermine the progress made and so set pandemic preparedness back? There is, of course, more to be done. What can be achieved will inevitably be a function of spending priorities. It is better, however, to focus on those steps which might not make a headline, but which will improve, in the long term, the country's resilience. And such steps include increasing the number of those with a science background in policy-making roles in government, attracting and retaining scientists and clinicians to undertake research within government, and giving licence to the civil service to look for innovation and to find ways of avoiding ending up working in silos. My lady, that's the statement for UKHSA. Thank you very much.
Thank you very much for your help, Mr. Hunt. Mr. Drysdale, I think you got moved, didn't you?
Good afternoon, my lady. Can you hear me?
I can, thank you.
My lady, I appear for the Scottish Government with my juniors Ian Halliday and Kenneth Young. The Scottish Government wishes to reaffirm its commitment to assisting the inquiry with examining what happened during the pandemic and reflecting on areas for improvement. It pays tribute to the many clinical, scientific and health and social care workers who responded to the major public health challenge. Frontline health and social care workers had a much greater risk of exposure to COVID by infection due to their work, but bravely continued to roll out the vaccine with support from a range of partners. The Scottish Government worked effectively, allowing decisions to be taken in extremely challenging and uncertain circumstances. The fast-moving public health emergency had to be matched by rapid decision-making, reflecting the development of scientific understanding and the spread of new variants. The overarching objective of the Scottish Government was to protect the population from the harms of COVID-19 and to minimise the loss of life. The vaccine rollout in the UK was the fastest in the world, and one of which we should be enormously proud. Across Europe, the greatest number of lives were saved in countries such as Scotland that implemented early vaccination programmes that reached high vaccination coverage. Vaccination through increased immunity allowed governments to reopen society as COVID-19 became less of a risk for the population, bringing hope that life could potentially return to normal. The Scottish Government recognises that there were many thousands of deaths and people left disabled directly or indirectly due to COVID-19, and in very rare cases from the vaccine itself. Each one is a tragedy. And it appreciates that the clinically vulnerable continue to feel the effects of the virus. In recognising the enduring loss suffered by so many, as highlighted in the Every Story Matters report, it is important to understand everyone's unique experience of what happened. The Scottish Government is committed to honouring those who lost their lives by ensuring that all available lessons and recommendations are learned in order to reduce the harm caused by a future pandemic. Due to time constraints, my lady, I'm unable to address all of the topics which will be covered in full in the Scottish Government's written closing statement. Instead, in this oral closing statement, I wish to address your ladyship on 4 key themes: equalities, delivery, messaging and data. Turning first to equalities, we are a multicultural society, and it is important that vaccine rollout reflects society, but it should also reflect a fairer society. Many underserved communities in Scotland experience poorer public health in general. This makes it even more important that they access vaccination. Barriers to vaccination must be addressed if the UK is to be prepared for any future pandemic. Maximising the number of people who could receive a vaccine or who could be protected from serious illness by therapeutics was an important part of the strategy in Scotland to reduce transmission and save lives. The Every Story Matters report states that some contributors from minority ethnic backgrounds described how previous experiences of discrimination and racism had led them to distrust the government and the health system more broadly. During the pandemic, the Scottish Government was aware that certain communities had relatively higher levels of mistrust in government and that working in partnership with them was necessary. Inequalities were routinely considered as part of decision-making. The Scottish Government worked with community organisations and charities to understand concerns and remove barriers. And since the pandemic, the Scottish Government has worked with Public Health Scotland and partners to ensure inclusion and equalities considerations continue to inform strategy and decision-making across all of Scotland's vaccination programmes. They provided for inclusion as a priority in Scotland's new 5-year vaccination and immunisation framework, a dedicated vaccines inclusion working group, permanent funding for inclusion-focused mobile vaccine units, and the ongoing collection and use of ethnicity data to inform decisions. Public Health Scotland engaged with stakeholders and undertook a health inequality impact assessment, which provided recommendations to health boards. Clear direction and guidance were issued to health boards from the Scottish Government, asking them to prioritise inclusive efforts. Each health board also carried out their own health inequalities impact assessment or inclusion plan, informed by their local community knowledge and engagement. The Scottish Government and Public Health Scotland worked together to capture data relating to uptake inequalities. The Scottish Government has focused on ethnicity data collection through the programme, which allowed the use of real-time disaggregated data to identify trends and concerns and target efforts towards those communities who were not accessing the vaccine. Some key issues that have been raised during this module were recognised and managed in Scotland throughout the vaccine rollout. For example, the Scottish Government worked with trusted partners to alleviate concerns from refugee and asylum seeker communities with tailored messaging. In addition, in Scotland, health boards were asked to put in place outreach for Gypsy, Roma and Traveller GRT communities, recognising a high level of historic distrust of authority within these communities. Partnerships were forged with local trusted figures to support engagement, and data was collected on uptake rates for GRT communities when the ethnicity data question was introduced to the Vaccine Management Tool, or VMT. The inquiry has heard evidence that a perceived lack of diversity in vaccine trials caused some members of minority ethnic communities to lack confidence in the vaccine. That underscores the need to improve the way in which public bodies across the UK work with traditionally underserved communities to build trust and confidence. Part of that will, no doubt, involve a step change in the way that data is held and used, as helpfully noted by Council for the Travellers Movement in this module. Recognising the need to have in place a single national system to record details related to COVID vaccine delivery, the Scottish Government developed the Vaccine Management Tool. Ethnicity data was collected in the programme from November 2021, with the addition of a mandatory question in the VMT. From March 2021, Public Health Scotland began to publish this detailed vaccine uptake by ethnicity and in areas of deprivation. This allowed both the public and decision makers to understand differences in vaccine uptake by population demographics, and it enabled the programme to respond and flex in response to real-time evidence of low uptake in underserved communities. Other vaccines have since been added to the Vaccine Management Tool, and the Scottish Government are committed to data improvement across all its vaccine programmes to ensure a continued focus on equalities. High confidence in routine immunisation must be built. This is particularly important in underserved communities with historically low uptake of routine vaccinations. Turning now to delivery and the Barnett formula, during the pandemic, Scotland received a share of vaccines calculated on the basis of the Barnett formula. The Welsh Government made a call in their opening statement for a needs-based formula for vaccine supply to the devolved nations instead. At the time of the pandemic, the Scottish Government was content with the Barnett share, noting that more comprehensive modelling to inform supply was not possible in the timeframe available and would have delayed vaccination. In general, the UK Government and UK HSA were willing to engage early and often with the devolved nations regarding supply and were clear on decisions. In terms of advanced planning, it's difficult to hypothesise on the nature of a future public health emergency and how vaccines should be distributed in that context. In general, Scotland adhered to the advice of the JCVI, but as the inquiry has heard, there were instances where this advice did not reflect the Scottish delivery approach landscape. Where this occurred, officials worked hard to develop a suitable approach or definition and communicate this appropriately. In Scotland, health boards are responsible for the local delivery of vaccination programmes. This decision was taken as part of contract negotiations between the Scottish Government and the British Medical Association on behalf of GPs in 2018. It was reasonable for the Scottish Government to divert the resource-intensive duty of mass vaccination away from GPs. This policy helped ensure resilience in the primary care sector in Scotland. The Scottish Government recognises the challenge of geography, particularly in the Highlands and Islands, and that in rural areas people may have had to travel longer distances to access vaccination. Mobile units were made available to reach these communities, and health boards used their local knowledge and real-time uptake data to pivot their approach to ensure suitable clinic availability. In addition, health boards worked with local partnerships and charities to mobilise volunteers and free accessible transport options to get people to their appointments. The Scottish Government recognised that attending a mass vaccination centre would not be suitable for everyone. A range of measures were put in place by health boards to ensure that the vaccine reached everyone. Work is ongoing with partners to ensure that all current and future vaccination programmes are fully accessible, no matter where in the country someone lives. Decisions taken regarding delivery, such as the vaccination of care home staff at the same time as care home residents, led to higher uptake among care home workers in Scotland. But it is difficult to compare uptake, as there were only marginal differences in the vaccination programmes across the UK. The uptake figures for the four nations are broadly in alignment. Turning now to messaging. Public health messaging in Scotland was broadly effective, demonstrated by the overall levels of vaccine uptake. Communications evolved in response to changing advice and evidence, as well as emerging insights, feedback and research. Increasing levels of fatigue, misinformation and disinformation impacted vaccine confidence and influenced the approach to messaging as the pandemic went on. Disinformation was a continual issue over the course of the pandemic and was particularly difficult to deal with on social media. The Scottish Government took an effective approach of repeating factual statements that countered this without being drawn into direct confrontation with the publishers. Trusted medical professionals were often used to deliver these messages, recognising high levels of public trust in the NHS. In addition, there was a dedicated team leader in the vaccine policy team responsible for managing disinformation, liaising with partners in Scotland, but also making connections with other UK nations. The former First Minister took a central, visible role in public messaging. And vaccination was promoted from an early stage as a positive intervention that would support easing of restrictions. The Scottish Government has already begun its work with partners to identify areas for improvement and embed learning into its vaccination programmes. In January 2024, Responsibility for national oversight of all vaccination programmes in Scotland was transferred to Public Health Scotland. And finally, my lady, turning to data, throughout this module, the inquiry heard evidence to the effect that the lack of accessible data hampered vaccine delivery across all 4 nations. At the start of the programme, there were challenges regarding accessible and publicly available supply data, which impacted the Scottish Government's ability to communicate appropriately with the public and build and maintain trust in the programme. This later improved as supply became steadier. The Scottish Government worked with partners to improve its programme data throughout the course of the rollout to ensure that it was able to plan its resources and approach appropriately. Its future pandemic preparedness programme of work has identified data as a priority area for improvement. My lady, in conclusion, the Scottish Government wishes to thank all those who have given evidence during Module 4 and to pay tribute to all those in the NHS and across society who served others during the pandemic by developing, delivering and administering vaccines and therapeutics. The Scottish Government is wholeheartedly committed to assisting the inquiry in fulfilling its terms of reference and identifying findings and recommendations. It is determined to emerge from the public health crisis with a stronger and fairer society, building on the common purpose within the vaccination and therapeutic pandemic response in Scotland. Now that we have emerged from this tough challenge, there is an opportunity to renew our country, building a fairer society with more equitable access to healthcare. The Scottish Government has laid strategic foundations to prepare its vaccination and therapeutic systems for the next pandemic, to improve routine immunisation programmes and to put it in a strong position to respond to new threats.
Thank you, Ms Drysdale. Mr Stanton.
Thank you, my lady. My lady, the closing oral statement of the British Medical Association is as follows. The BMA's position remains, as stated at the outset of these hearings, that the COVID-19 vaccination programme was one of the biggest successes of the pandemic, as clearly demonstrated by the estimate of the UK HSA, that as at September 2021, vaccination in the UK had prevented more than 24.3 million infections and over 123,000 deaths. The BMA also recognises and commends the speedy development and authorisation of the vaccine, which took place without compromising safety. However, the BMA's interests in this module primarily relate to vaccination rollout and deployment, and in particular the following: the role of general practice in delivering the vaccination programme, barriers to vaccine uptake, workforce planning and capacity, data sharing, and vaccination as a condition of deployment. In respect of the role played by general practice, the BMA considers that GPs and their practice teams made a major contribution to the success of the vaccination programme. The BMA proactively made the case in England that the vaccination programme should be delivered by general practice, and the inquiry heard from Dame Emily Lawson that in England, GPs were the right model, particularly for the most at-risk priority groups, including care home residents and the elderly. This use of existing infrastructure and delivery of vaccinations at a local level was highly effective, and by the end of October 2021, 71% of vaccines in England had been administered by GPs and their teams and community pharmacies. The inquiry was told that many people felt more comfortable and had greater levels of trust in receiving their vaccination from their local GP rather than at a vaccination centre. GPs have substantial experience of delivering vaccinations and have existing knowledge and relationships with their patients, particularly elderly patients. This, coupled with the proximity of GPs to their local populations, helped overcome barriers to access. In addition, GPs have the experience to address questions or concerns about the vaccine and to encourage uptake in their local communities. And as confirmed by the UK HSA, being able to receive a vaccine in a familiar environment can support public confidence. My lady, turning to barriers to uptake, the inquiry has heard a substantial volume of evidence on disparities in vaccination uptake amongst different population groups, including ethnic minority communities, migrants, Gypsy, Roma and traveller communities, disabled people, and those living in deprivation. These disparities highlighted long-standing problems of inclusion within UK healthcare systems, and it was well known before the pandemic that there was a historic mistrust of healthcare system and vaccines within certain communities. A 2016 report of Public Health England on flu vaccination showed lower uptake by people from ethnic minority backgrounds than for people with white British or white Irish backgrounds. And this trend was also seen in the lower rates of COVID-19 vaccine uptake amongst ethnic minorities. Again, with vaccine uptake highest amongst those from a white ethnic background. The inquiry also heard that deprivation was a factor in lower uptake in all groups, with vaccine uptake higher in areas of greater affluence, something the BMA highlighted in its 5th COVID-19 review report. People from ethnic minority and deprived communities had worse health outcomes before the pandemic and had a higher likelihood of becoming infected with and experiencing severe symptoms from COVID, not least because of wider health inequalities. Disabled people were also at significantly greater risk from COVID and from dying as a result of infection. With this in mind, the BMA submits that there should have been greater consideration of these groups when planning the vaccine rollout. Professor Van Tam's witness statement reflects this position and sets out that, quote, "It is well known that vaccine uptake tends to be lower in marginalised, deprived and ethnic minority communities. It was therefore foreseeable that a similar pattern would be observed when it came to delivery of the COVID-19 vaccines, as indeed it was. It is therefore arguable that more should have been done in the planning phase to consider this." End quote. The mechanisms of the programme also on occasion caused barriers to vaccination. For example, although disabled people were a focus of prioritisation, the less than full identification of people living with a learning disability and a lack of clarity on the level at which a learning disability provided priority eligibility created a barrier in accessing vaccination for this vulnerable group. This must be addressed in advance of any future pandemic to ensure that the main means of offering vaccination in a mass vaccination programme does not rely on self-identification. The inquiry also heard of physical barriers preventing vaccine uptake, such as the distance to a vaccination site, the cost of transport, and difficulties or concerns for the clinically vulnerable, disabled, elderly, or housebound from attending a vaccination centre. The lack of an NHS number also presented issues for people in the homeless population, the Gypsy, Roma and traveller communities, and vulnerable migrants. The BMA recognises that efforts were made to address vaccine hesitancy and to overcome barriers to accessing vaccines, but more still needs to be done to instil confidence. Evidence before the inquiry supports ongoing engagement with marginalised and underserved communities, which has been lacking. The disparities in access and uptake to the vaccine laid bare the disparities in access to healthcare more broadly and highlight an important area for governments across the UK to prioritise for urgent improvement. As the inquiry's experts in vaccine delivery and disparities warned, quote, "We cannot be complacent. We have to be continuously promoting uptake of vaccinations, and it needs to be resourced." End quote. Misinformation and disinformation also contributed to vaccine hesitancy, and the inquiry has heard about these issues from a number of witnesses in these hearings, including the Director General with overall responsibility for the Counter-Disinformation Unit, who told the inquiry that disinformation is defined as the deliberate creation and dissemination of false information, which is intended to deceive and mislead, and misinformation is the same but without the deliberate intent. During the pandemic, the BMA ran its own social media campaign to address vaccine hesitancy and called on the UK government to take more action to tackle misinformation online. It goes without saying, then, that the BMA entirely rejects the assertion made by the former Minister for Equalities, Kemi Badenoch, in her oral evidence that the BMA was itself responsible for misinformation. The background circumstances to this issue are that the BMA raised legitimate concerns in June 2020 within a number of letters to Ms Badenoch and the Secretary of State for Health and Social Care, following publication of the Public Health England review into inequalities and disparities. And my lady, you heard evidence on this issue in Module 2. The BMA had anticipated that the review would address why there was such disproportionate deaths and serious illness in healthcare workers from ethnic minority backgrounds. However, when the review was published, it failed to address the staggeringly higher proportion of deaths amongst healthcare workers from ethnic minority backgrounds. In response to Ms Badenoch's criticisms, Professor Banfield, the BMA's chair of UK Council, issued an immediate public response on Monday of this week, which concluded, quote, "To suggest the BMA was spreading misinformation at this time is highly disingenuous. All we were doing was asking the government to be transparent about how and when it was planning to take action to save lives and address racial inequalities." In respect of workforce planning and capacity, the BMA's view is that general practice was the right delivery vehicle for COVID vaccination. However, the BMA remains concerned that insufficient consideration was given to workforce planning in connection with the vaccination programme, and that delivery of the programme further reduced the already limited workforce capacity in general practice, with GPs and other healthcare workers required to work additional hours to administer vaccinations while still continuing to deliver COVID and non-COVID care. During the pandemic, the BMA engaged with NHS England and the Department for Health and Social Care to address the increasing demands on general practice, the rising workloads and workforce shortages, and made clear that general practice was at breaking point and there were simply too few GPs. Against this background, the comments made in the published witness statement of the former Secretary of State for Health, Sir Sajid Javid, that the BMA sought to take commercial advantage of the vaccination scheme are shameful and offensive and expose complete ignorance of the reality for GPs on the ground, including the overwhelming demand, the lack of capacity, and the abuse faced by GPs and their staff while they did their best to manage unmanageable workloads. The vaccination programme was substantial additional work that general practice delivered in the national interest, requiring existing or additional staff to take on increased hours, often at weekends. It did not result in GPs being paid twice, as alleged, and the efficiency with which GPs delivered vaccines was more cost-effective than cost per dose at mass vaccination centres. My lady, on the question of data sharing, access to GP data is subject to a number of checks and balances. These are put in place to preserve the integrity of the doctor-patient trust relationship and to ensure that GPs uphold their obligations as data controllers under GDPR. However, the BMA was broadly supportive of measures put in place to support the UK's pandemic response, which lowered the threshold on access to GP data. The inquiry heard evidence that such measures should be brought back to enable better sharing of health data. The BMA agrees that improved data sharing is essential to providing safe, high-quality healthcare and to enable healthcare services to respond to emergencies, such as a future pandemic. However, great care must be taken to safeguard patient confidentiality. Finally, my lady, on the issue of vaccination as a condition of deployment, or VCOD, the inquiry has heard differing views on the merits of this policy. The BMA's position is that it strongly urges doctors and frontline healthcare workers to be vaccinated, and uptake amongst doctors of the COVID-19 vaccine was high. But the BMA considers that mandating vaccination is not the right approach and would worsen the existing recruitment and retention crisis within health and social care, as seen when the policy was implemented for a short period of time within social care in England, which caused significant reductions to the workforce. COVID-19 vaccines have been very successful at controlling serious disease and death, but they do not prevent transmission. And Professor Sir Chris Whitty, while acknowledging that VCOD was a political decision, expressed his scepticism that it was a good idea and told the inquiry that mandation has not got a very happy history. He also highlighted that doctors have a clear professional responsibility to protect patients by having vaccinations, but said that there is a big difference between responsibility and mandating it so that you lose your job. A similar view was held by Dame Jenny Harris, who advised in February 2021 that there was no evidence that the policy would have more benefit than harm. In conclusion, my lady, while there is no doubt that the COVID vaccination programme was a success, there are lessons to be learned from this experience and from vaccination programmes before it that can lead to increased uptake and reduced disparities, which will in turn further reduce the risk of infection and save more lives. My lady, thank you to you and your team for facilitating the core participation of the BMA at the inquiry.
Thank you very much, Mr. Stanton. Mr. Mingo, I won't cut you off before the break as I did last time.
Thank you, my lady. My lady, this is the closing statement on behalf of the National Pharmacy Association. Over the past 3 weeks, the inquiry has heard evidence from many sources of the vital role played by community pharmacy in the delivery of the COVID-19 vaccination programme and of the efforts made by the National Pharmacy Association on behalf of its members to advocate for an increased role for community pharmacy in supporting vaccine delivery. The NPA welcomes the inquiry's scrutiny of the rollout of the vaccination programme, and particularly those areas where there are lessons to be learned for the future. This statement for the NPA seeks to address 2 broad points arising from the evidence heard in this module. First, the key role that community pharmacy played in the success of the vaccination programme and the need for early involvement of community pharmacy in planning and delivery for future vaccination programmes. And secondly, the role of community pharmacy in addressing health inequalities, overcoming barriers to vaccination, encouraging vaccine uptake and countering vaccine hesitancy. Primary care, including community pharmacy teams, were crucial to the successful delivery of the COVID-19 vaccination programme, and all 4 UK nations relied on community pharmacy to differing extents in ensuring that vaccines were readily available throughout the country. Community pharmacy teams have helped to protect and save the lives of tens of millions of people in the UK. Given its years of experience and expertise in delivering annual flu vaccinations, and given the reach and resources of the approximately 13,000 community pharmacies embedded in communities across the UK, community pharmacy is ideally equipped to deliver a vaccination programme. The inquiry has heard that the COVID-19 vaccination programme benefited from the infrastructure already in place for the delivery of routine immunisation programmes, and that programmes delivered at local level have proved highly effective. However, as the inquiry has also heard, community pharmacy was not involved in the initial phases of the rollout, in large part due to the programme requirements in England that vaccination sites administer at least 1,000 doses per week and remain open 12 hours a day, 7 days a week. The NPA voiced concerns that community pharmacy was underutilised in the early days of the rollout, and evidence before the inquiry shows that in January 2021, the Prime Minister also questioned whether enough was being done through community pharmacies. Amongst the reasons put forward for not including community pharmacy from the outset were the difficulties transporting and storing the Pfizer vaccination. And while the NPA well understood these challenges, by early January 2021, the Oxford AstraZeneca vaccine was available and was very suitable for community pharmacy to deliver. The requirement of 1,000 vaccines per week was, in the NPA's view, no longer required and risked creating new health inequalities. It has also been suggested that it was supply constraints which demanded that vaccine sites deliver 1,000 doses a week, and this approach was devised to protect as many people as quickly as possible in the fairest way possible. However, the very first COVID-19 vaccine delivery plan issued by DHSE on the 11th of January 2021 emphasised that local vaccination services, including community pharmacy sites, provided the largest number of sites, supported the country's highest risk individuals, and delivered vaccination to people unable to attend vaccination centres, including reaching vulnerable groups such as the homeless. This document recognised that community pharmacies are integral parts of local communities and will be accessible and approachable places from which to deliver vaccination. The NPA submits that the balance reached in the early part of the vaccination programme, prioritising large vaccination centres in favour of a higher number of local sites, was wrong. A more balanced approach that relied on existing health infrastructure, including the extensive network of community pharmacies across the country, would have ensured broader, more equitable access to the vaccine at an earlier stage, and could have been achieved had community pharmacy been consulted and involved earlier in the planning process. As a final point on the role of pharmacists in vaccine delivery, and as mentioned in the MPA's opening statement, the MPA asks the inquiry to take account of the impact of delivering the vaccination programme in a system that was already stretched to breaking point by the pandemic. Healthcare workers in community pharmacy and general practice provided crucial vaccination services on top of existing commitments, and any future vaccination programmes must ensure that experienced health professionals have sufficient capacity to deliver the programme in a safe and sustainable way. The second broad area relates to vaccine uptake, barriers and hesitancy. The inquiry has heard of the benefits of working at local level through general practice and community pharmacy, including high levels of patient registration, the ability to rapidly identify clinical at-risk groups, and the value in being able to receive a vaccine in a familiar environment which supports public confidence. The inquiry's expert in vaccine hesitancy, Professor Larson, told the inquiry that access was a big issue and, to quote, "The more we can try to engage locally, and again, that doesn't have to wait and shouldn't wait for another crisis, whether it's through a local GP or a pharmacy, the more we can bring vaccines closer to people is only an asset." Many witnesses have described the trust relationship that exists at a community level, and GPs and community pharmacists have been described as by far the most trusted health professionals in their communities. Approximately 50% of the NPA's membership are from ethnic minority backgrounds, and their role as trusted healthcare professionals at the heart of their communities allowed them to respond to the needs and concerns of their patients, addressing health inequalities and vaccine hesitancy within their communities. Their ability to debunk myths and misconceptions improved vaccine uptake, particularly in patients who expressed scepticism about the vaccination. Community pharmacies are disproportionately located in poorer areas, and they play a particularly important role in deprived and rural communities, which often have less access to other healthcare services and where there are increased barriers to accessing a vaccination centre. Community pharmacies are accessible without an appointment, and 99.8% of the population in areas of highest deprivation have access to a community pharmacy within a 20-minute walk. Community pharmacies have tried and tested mechanisms of reaching out to patients to reduce vaccine inequity in local populations, as well as being innovative in delivering patient care. The NPA's witness statement in this module included the following account from a member pharmacy that had set up a process with their local director of public health to vaccinate individuals from marginalised communities. The pharmacy team recognised the importance of vaccinating people from inclusion health groups, given they are already experiencing significant health inequalities and are at high risk of poorer outcomes should they contract COVID-19. Inclusion health groups comprise people who might struggle to access mainstream healthcare and include vulnerable migrants, asylum seekers, refugees, people experiencing homelessness, sex workers, gypsy Roma, traveller communities, and people struggling with addiction. The walk-in model was particularly useful for helping inclusion health populations who are typically not registered with a GP and have no NHS number or access to the COVID-19 vaccine, as they are unable to use the National Booking System appointment system. The NPA believes that the significance of vaccine hesitancy and other barriers to vaccine uptake were not fully appreciated early enough. Barriers to vaccination need to be understood and addressed at a community level. And again, the early involvement of community pharmacy in planning could have better identified these issues and allowed greater scope for the positive role that community pharmacy can play. To conclude, my lady, the inquiry has heard that throughout the relevant period, community pharmacy delivered just under 21% of all COVID vaccinations in England. And in the recent winter campaign for flu and COVID, community pharmacy delivered over 40% of vaccinations. As highlighted by Dame Lawson, the role that pharmacy plays in vaccination, particularly in areas which are underserved by both primary and secondary care, is absolutely vital. The NPA believes there is substantial scope for community pharmacy to play a greater role in vaccination planning and delivery, which will benefit future pandemic preparedness. Thank you.
Thank you very much, Mr. Migo. We'll take our break now. I shall return at 25 past. Not quite.
Right, let's try again. Yes.
Gotcha. Yep.
My lady, the Traveller Movement is grateful to you for the opportunity to participate in this module of the inquiry. Public inquiries are important because they are capable of catapulting significant but perhaps neglected issues into public consciousness and into the minds of institutions which hitherto failed to act appropriately when needed. And as a result of its participation in your inquiry, the Traveller Movement believes that the sands have shifted insofar as there is now an institutional awareness and public understanding that Roma, Gypsies and travellers were largely abandoned in the vaccination programmes. And importantly, that they were in many ways statistically invisible and not properly captured, certainly in England, in census records and other national data. It was uncontentious during the rollout in December 2020 that the traveller communities were a health inclusion group. And that means that by virtue of social exclusion, poor health outcomes and a high risk of missing out on vaccination, they were particularly vulnerable. Yet it's clear from the limited data that we have and the compelling evidence given before you by Ms McNamara on the 16th of January that not enough was done to address the significantly low uptake of vaccines that ensued. My lady, the evidence over the last 3 weeks has confirmed that the level of institutional failure towards the 3 GRT communities was indeed significant. You will recall that the Director of the Public Health Programmes at the UK Health Security Agency, Dr. Ramsey, stated in her evidence on the 21st of January, in answer to questions from ourselves, that apart from a single workshop, she was not aware of any concerted effort at national level to ensure the inclusion of GRT and targeting of GRT into the vaccination programme. Furthermore, my lady, on the 27th of January, Kemi Badenoch, the Minister for Equalities at the time of the vaccine rollout, was asked again by ourselves about the lack of targeted initiatives such as pop-up clinics or bespoke community engagement in respect of travellers. And she said that it was her understanding that there were GRT-based activities, but that of all the groups that the government was trying to reach, this was the most difficult group. Ms Badenoch went on to say that the lack of engagement with travellers might have been down more to the fact that GRT were difficult to reach rather than simply because nothing was done. Significantly, she clarified that she might be able to explain this, but not as a minister, but from her experience as a constituency MP, where she had noted that there was a hostility to state bodies within the communities. My client is keen to impress upon the inquiry that the underlying reason why some members of the traveller community appear to be hostile or reluctant to interact with the state lies in the fact that discrimination and marginalisation necessarily breeds distrust and non-cooperation. And this is particularly applicable in a number of pockets of chronic exclusion around the UK, such as unregistered sites, where, as we've already stated, approximately 10,000 travellers are forced to live as a result of local authorities failing to meet spatial planning requirements. I gave examples in my opening submissions of discrimination during the pandemic, deaths occurring because ambulances were required to wait for police escorts before entering sites, and heavy police presence at funerals. You will recall that Miss McNamara told you in her evidence on the 16th of January about cases where police were sent to sites to stop residents going out to buy fuel for generators, those very generators which were used to power the refrigerators on sites that stored medication. My lady, I echo what Mr. Thomas King's Counsel told you earlier. It's about trust. Trust is vital. The fundamental problem with the authorities' approaches to the GRT communities is that prior to the pandemic, only very limited steps were taken to proactively engage to address mistrust and lack of cooperation. So by the time of the vaccine rollout in December 2020, as Ms. McNamara put it so well, the flood had already started, and it was too late to build the ark. And that chimes, my lady, with the evidence of Dr. Chantler on the 27th of January. And she said there needs to be an ability to build trust and relationships so that you don't have to suddenly gather people together. My lady, the way to generate trust is through effective community engagement. And the two are very much connected and equally important. Ms. McNamara confirmed that mobile health services for the GRT community are no longer in existence, and that this important outreach should be reinstated because it had been crucial to building the relationships with communities that are so needed at times of health crisis, for example. Ms. McNamara went on to say that the mobile health services, when in existence, had allowed people to have someone they could go to with health concerns or issues, who they could build up relationship of trust and confidence with. She stated that these services might have proved very useful when the vaccinations were rolled out, because questions about vaccinations would have been dealt with by health professionals who the travellers knew and trusted, and in circumstances where the travellers would be more familiar with the healthcare system. Dr. Richardson said on the 28th of January that it is important that the message is transmitted by the right messenger, and my client couldn't agree more. Lady, you will recall that misinformation was a significant issue for the GRT community. Ms. McNamara told the inquiry that rates of child mortality and miscarriage are high in these communities, and that rumours spread to the effect that vaccines could lead to infertility in children, to infertility and autism in children. These rumours spread quickly through what is traditionally an oral community and went unchecked. And it's important to note that a community which suffers from digital exclusion and literacy issues is not only less able to receive vaccine invitations by letter or look at government alerts on the internet, but will also be unable to access government messaging so as to counter misinformation. My lady, I spoke earlier in relation to the evidence about the lack of any meaningful initiatives at national level to ensure the inclusion of GRT and targeting GRT into the vaccination programmes, the evidence that was given by the Director of Public Health Programmes. Regrettably, it was the case that local interventions were also sparse, particularly in England. aside from local programmes at the Appleby Horse Fair and an initiative in Shropshire involving a well-known TV figure, there doesn't appear to be any evidence that much was done at a local level in England. Witnesses have pointed to the Community Champions scheme, but the traveller movement maintains that this initiative did not address the problem of low vaccine uptake, notwithstanding that local authorities had an awareness, of course, of where the traveller sites, or some of them at least, were located. The situation was handled much better in Scotland, as Ms Drysdale, King's Counsel, on behalf of the Scottish ministers, has set out in her submissions today. We note that Mr Grieve told the inquiry on the 28th of January that the Scottish Government's approach was to respond to feedback that they received from particular communities. And there was evidence in a February 2022 Scottish Government document entitled Inclusive Vaccinations, Phase 1 of the COVID-19 vaccination programme, INQ 000376293, that the National Health Service in Scotland worked with local authorities and ambulance services and visited traveller sites in the Forth Valley and the Boswell Fair to deliver vaccination. My lady, I turn, perhaps as I must, to the issue of data. The traveller movement's position is that problems of lack of trust and lack of engagement were compounded by the fact that GRT, which, as we've said, constitute possibly up to 1% of the UK population, are statistically invisible, and particularly in England. Now, as I pointed out in my opening submissions, the contrast between data capture in Scotland and in England is shown at pages 58 and 59 of the expert report of Dr. Castander-Bush and Dr. Chandler. My lady, of course, I don't have time to put all this on the screen, but you will note at page 59, when you come to analyse the report, that there's a table containing the Public Health Scotland data, where GRT are recorded as the highest unvaccinated group, as I've said, at 55% unvaccinated, and the least likely group to receive at least one dose. Yet on the preceding page, if you go back in the report, you'll see the data from England that fails to refer to the GRT groups at all. These communities are nowhere in sight as far as the English data is concerned. And Dr. Chandler helpfully confirmed in his evidence on Tuesday that in England, healthcare records do not routinely record membership of certain health inclusion groups. And we've heard this in other evidence. The government's final report on progress to address the COVID-19 health inequalities, or the quarterly review, you might recall, dated December 2021, so a year before the rollout, that confirms, and it's INQ 000089747, at page 124, that vaccination estimates for Gypsy, Roma and Irish traveller populations are not available, as NHS systems do not have these categories available to choose. So it was out in the open. The same report recommends at pages 134 and 136 that it was a high priority next step to improve ethnicity coding in health data sets, amongst other things, to allow information for the GRT groups to be presented. Yet it appears, of course, that this recommendation has not been implemented. Dame Emily Lawson accepted in her evidence in answering Mr. Keith, King's Counsel, on the 28th of January, that we would not find any figures relating specifically to GRT in the NHSE documentation. And she confirmed that GRT are not in the NHS data dictionary. Now, Dame Emily also said in her evidence that ethnicity data was in the process of being updated. But you will recall that Ms. McNamara also said on the 16th that her organisation, the Traveller Movement, for whom I act, has been calling for such inclusion since 2012. My lady, it's just unacceptable that this situation is permitted to continue. And we say that if the inquiry makes any recommendation in relation to GRT, and we hope there will be more than that, but if it makes any one recommendation, it must emphatically recommend that the NHS changes its data recording procedures to include the GRT communities. It is self-evident, of course, that data capture has a strong bearing on vaccine uptake. You will recall that Ms. McNamara told the inquiry that without proper data capture, GRT community members would not have received NHS text messages that were sent out to vulnerable communities during the pandemic. And Dr. Castander-Bush referred to GRT in his evidence on the 28th of January, and he said that you need an NHS number to be called up in the first place. One would have thought quite obvious, really. TM's uncontroversial position is that without inclusion in NHS data, people are going to be overlooked in local and national health strategies and delivery. And that's what happened in the COVID pandemic, and it will happen again if not addressed. There's another issue to which Ms. McNamara referred in her evidence, which I want to address briefly, which is that GRT are no longer provided with handheld medical records. Now, this was a measure that addressed the long-standing problem of inclusion in healthcare that GRT face, where, for example, GRT members relocate frequently between sites or between houses. And we ask you to recommend that the system of providing handheld records for members of the GRT communities is restored. These records would make it easier to register with the GP and might break the pattern of travellers being turned away from surgeries. GP registration is, of course, important. As Ms. Stevenson of Council put to Ms. McNamara on the 16th of January, the invitations to vaccinate were linked to GP registration. If you're excluded from the system, you're just not going to get the information. It's noteworthy that many GRT members did not have an NHS number during the pandemic, and that in itself amounted to an impediment to obtaining a vaccination dose. In conclusion, my lady, I would repeat what I said in my opening submissions. There are three actions which would have been effective to improve immunisation uptake amongst the GRT communities. These are, firstly, maintaining trust within the traveller groups locally, secondly, specialist health attendances on GRT, and thirdly, high-quality data. And these are effectively the recommendations that we seek. Having heard the detailed evidence over the last 3 weeks, it is even clearer that these measures are needed. It should now be uncontentious that unless the authorities take appropriate steps to establish trust with the GRT communities, restore specialist health visitor outreach services, and capture high-quality data describing family ethnic groups, the mistakes that were made, and they undoubtedly were made, around vaccination in the COVID-19 pandemic will be carried through into any future pandemic. My lady, the traveller movement asks that you recommend that these measures are implemented by policymakers now. Dr. Castan Dabush told the inquiry on the 28th of January that there is a need to create an agenda for change in partnership with underserved groups, and my client emphatically agrees. Furthermore, these problems don't just arise when there is a pandemic on the horizon. As Mr. Stanton, on behalf of the BMA, stated before the afternoon break, Dr. Chandler told the inquiry in her evidence that we cannot be complacent. She said we have to be continually promoting uptake of vaccinations, and this needs to be resourced. Now, finally, my lady, your inquiry represents a once-in-a-generation opportunity to address vaccine inequality within these three highly marginalised and vulnerable communities. And we submit, or the traveller movement submits, that the inquiry must make robust recommendations to ensure GRT engagement and inclusion in the future. I repeat Ms. McNamara's very apt analogy. You can't build the ark after the flood has happened. And we say that building process must start now, unless I can assist further.
Thank you very much indeed for your help, Mr. Jacobs. Ms. Parsons, are you over there?
My lady, I make this closing statement on behalf of the COVID-19 bereaved families for Justice Cymru. By way of introduction, as the inquiry is aware, a priority of the COVID-19 Bereaved Families for Justice Cymru group is to scrutinise whether the Welsh Government discharged its duty to protect the lives of people in Wales. This closing statement flags key concerns of the group in relation to that issue. It will focus, in particular, on the delivery of vaccinations in the first few months of the programme to the most vulnerable groups in Wales. It is important, when considering these issues, to remember what a devastating period this was, with care homes in Wales experiencing 465 COVID-19 related deaths in January 2021 alone, and at times as many as 20 deaths a day. Vaccinations in Wales commenced on the 8th of December 2020. However, by the 16th of February 2021, over 2 months later, only 82% of care home residents in Wales had been vaccinated. Whilst at first blush that might seem a high proportion, in fact it was significantly below some of the other Phase 1 priority groups. This was despite the JCVI having identified care home residents as the most vulnerable group and the first priority group on the list. The source of this information is the Welsh Government's vaccination update. That's at INQ 000410143. This update also demonstrates that during February 2021, up to the 16th of that month, almost no vaccines were delivered to care home residents. Time was of the essence for many vulnerable people in Wales, as powerfully described by the group's co-lead, Sam Smith-Higgins, from whom, my lady, you heard earlier this month. She told the inquiry about her fears for her 73-year-old father, who was admitted to hospital in January 2021 for cancer-related treatment and was immune-suppressed and vulnerable. Ms. Smith-Higgins made efforts to secure a vaccine for her father prior to his admission, but was told this was not possible. Tragically, just 3 weeks after being admitted to hospital, he died from a COVID-19 related infection acquired in hospital. So against that backdrop, my lady, the key concerns. Key concern number 1, the Welsh Government's decision to deliberately slow the rate of vaccine delivery and its failure to vaccinate in accordance with JCVI priority cohorts. The group's members are extremely concerned at the decision of the Welsh Government to intentionally slow the delivery of vaccines in January 2021 to vulnerable people. And the group requests, my lady, that the inquiry gives this matter careful consideration. The former First Minister, Mark Drakeford, made a public statement on the 18th of January 2021, explaining that vaccinations in Wales would be staggered because, I quote, "it would be logistically very damaging to try and use all of that in the first week and then have all of our vaccinators standing around with nothing to do." Close quote. This bizarre statement was roundly criticised, and it might be thought to be an off-script comment made in error. However, it was in fact the policy of the Welsh Government, as seen from the ministerial advice to the First Minister, Mr. Drakeford, on the 24th of November 2020. That is at INQ 000361639. That ministerial advice stated as follows. Given the constraints around transportation of the Pfizer vaccine to care homes, it is recommended that the vaccine is not used in care homes for the first 4 weeks of delivery. Close quote. This policy, my lady, was also contrary to the JCVI priority cohorts and to the approaches taken in other UK countries, as can be seen from the Cabinet Office meeting minutes of the 12th of January 2021, and those minutes are at INQ 000088889. The minutes read as follows. 300,000 doses had been delivered to Wales, but short of 90,000 had been used so far. The press had picked up that this was down to the Welsh Government. It would be useful to have regular publication of how many vaccines had been delivered. The Welsh Government's approach was slightly different to other nations, as it had prioritised NHS staff for the Pfizer vaccine. Close quote. And my lady, you heard the anger and confusion that this decision, the decision to delay the vaccination to vulnerable people, had caused people in Wales. Ms. Smith-Higgins told you in her evidence. quote, the vaccinations had started coming out on the 8th of December, and I was a carer for an 85-year-old, my mother, so I expected her to be vaccinated relatively soon. But as December went through, I was tweeting like mad everybody, MPs, MSs, head of NHS, saying, what is going on? Why hasn't my mother been vaccinated? And it soon became apparent that actually in Wales, they were focusing on the healthcare workers and not aged or the most vulnerable. By the 11th of January, Cardiff and Vale Health Board tweeted that up to that date, up to the 11th of January, they had vaccinated 12,300 people, of which just 69 were in care homes, and only 75 were over 80. The group wishes to make clear that they take absolutely no issue whatsoever with the prioritisation of frontline healthcare workers, as advised by the JCVI. But that wasn't what happened in Wales, with significant numbers of administrative staff vaccinated before the vulnerable. Ms. Smith-Higgins refers in her witness statement to one such example, a relative in her 50s with no underlying health conditions who worked in an administrative department of one of the Welsh health boards and who received her vaccination as early as December 2020. The concern and anger about this issue was amplified by the history of neglect of care homes in Wales during the pandemic. This was epitomised, my lady, by the evidence of the former First Minister Mark Drakeford in Module 2B, when he told the inquiry, and I quote, there is no single register of where every care home in Wales is located, close quote. This, of course, begs the question, how is vaccination progress being managed and monitored among this most vulnerable priority group when the government didn't even know of their existence? The group, many of whom witnessed the death of their loved ones from COVID-19, want to know how many deaths could have been prevented if the Welsh Government hadn't delayed the vaccination in December 2020 and January 2021. They want to know how many deaths could have been prevented if the Welsh Government hadn't prioritised non-frontline healthcare workers over older people and the vulnerable. Key concern number 2, my lady. Over-reliance on a small number of mass vaccination centres, despite the geographical and demographic challenges of Wales. The group is concerned at the decision of the Welsh Government to heavily rely on delivery through larger vaccination centres. This decision is particularly difficult to understand given the geography of Wales, with many rural and remote communities, and also the demographic of Wales, which, as explained by Dr. Richardson in her oral evidence, is an older population with greater healthcare needs than other parts of the UK. My lady may recall the evidence of Sam Smith-Higgins when she told the inquiry that the mass vaccination centres in Wales covered huge geographical areas, requiring lengthy journeys by car, bus, or several buses. She told the inquiry, quote, for people who have been shielding for months and months and months to suddenly have to take an hour-and-a-half journey within the same health board and then stand outside for an hour and a half queuing to get into a sports centre, it just wasn't the best thought out, close quote. The group wants to know why the Welsh Government used this model, a person-to-vaccine model, rather than a vaccine-to-person model, when it would have been so obviously a disadvantage to those who were vulnerable and or who could not travel. The group believes that trusted healthcare professionals, such as GPs and community pharmacists, who are embedded within communities and easily accessible, were insufficiently utilised by the Welsh Government in the delivery of vaccines compared with other UK countries. The group believes that this was a missed opportunity by the Welsh Government. The group also believes that the difficulties of storing and transporting the Pfizer vaccine, while real, are too often relied upon to explain away poor performance or justify poor decisions. The Oxford AstraZeneca vaccine became available at the beginning of January 2021 and was widely used in Wales from this time, as can be seen from a Wales COVID-19 vaccination programme daily situation report. That's at INQ 000505456. That is a daily situation report of the 29th of January 2021, and it records that some 138,000 AstraZeneca vaccines had been delivered by the end of January 2021. The ministerial statement of the former Minister for Health and Social Care, Vaughan Gething, in his statement made on the 4th of January 2021, described the AstraZeneca vaccine as a game changer. He said as follows in his statement: "Members will be aware of the widely reported benefits of this latest vaccine. It is cheaper and supply will be more plentiful. However, crucially, it presents significantly fewer logistical challenges than the Pfizer vaccine, with storage at normal fridge temperatures. As NHS capacity continues to build over the coming weeks, we will be able to get the vaccine to where it is needed in every part of Wales. Much more flexible and mobile deployment models will be activated. Every care home will be within reach, and this priority group will be a key focus for the NHS over coming weeks." In these circumstances, my lady, the group submits that it is clear that the issues experienced in storing and transporting the Pfizer vaccine cannot be used to justify poor decisions and performance, such as the over-reliance on mass vaccination centres and the delays in vaccinating the most vulnerable. Key concern number 3, communications. The group's experience of Welsh Government is that it is strong on rhetoric and weak on delivery. And they submit that this was also a feature of the delivery of the vaccination programme. The first milestone of the Welsh Government's strategy was not based on the number of vaccines delivered, but on the number of invitations issued to JCVI priority groups 1 to 4 for their first dose vaccinations. Vaughan Gething announced on the 12th of February 2021 that this first milestone had been met. There are many things wrong with using a meaningless metric, such as the number of invitations issued, as a milestone, including, as already indicated, the fact that at the date of the achievement was announced, only 82% of care home residents had received their first dose of the vaccine. However, its lack of substance is best illustrated by the experience of Miss Smith-Higgins, as she explained in her witness statement. An invitation was sent out to her father 1 week after his death. No doubt, an invitation which helped the Welsh Government meet its milestone. Further, measuring achievement in such a superficial way takes no account of the difficulties experienced by the many who did not receive their invitation, or who received an invitation but experienced difficulties booking and travelling to an appointment, or, as in the case of many care home residents, those who were still waiting for their vaccination to be administered at the point the Welsh Government announced it had met its milestone. And there were also communication problems in relation to the vaccine themselves. The Audit Wales report reported on the rollout of the vaccination programme in Wales and identified a number of problems. That's at INQ 000066528. By way of example only, there were problems with identical letters inviting people for the first and second doses, and there were problems with the clarity of the invitations themselves, which used English and Welsh interchangeably over several pages of information, making it very difficult to understand. Those are the communication difficulties. Turning, my lady, to the fourth
I'm
point.
afraid you're going to have to take it very quickly because you're substantially over time and I've got to be fair to everyone. I'm sorry, Mr. Parsons.
My lady, I will in that case wrap up by referencing one more concern about the policy before concluding, and that was that the policy adopted was to proceed to vaccinate the next priority cohort once only 50% of the vaccination had been achieved in a higher priority group, which may explain perhaps why by mid-February 2021 there remained so many care home residents still to be vaccinated. And I turn to my concluding remarks, my lady. I've already identified the concerns that the Bereaved Families for Justice Cymru invite you to consider. But may I say this, by way of conclusion, the group is conscious of the need for the inquiry to deliver its work within a reasonable timeframe. However, it has been disappointed at the limited time spent in this module on issues specific to Wales. As we know you are aware, my lady, the inquiry's proceedings take a very significant toll on the families who are engaged. And this is particularly so for families in Wales who have to contend with a government that has exhibited, in earlier hearings, a remarkable ignorance about the issues for which they were responsible, whose actions do not match their words, and prominent members of which have destroyed potentially relevant information. The group remains wholly committed to your inquiry and looks forward to working with your inquiry team in future modules to hold decision makers in Wales to account. My lady, thank you.
Mr. Parsons. Mr. Wetherby.
Thank you. Through our opening submissions, the COVID Bereaved Families for Justice UK families have been clear to highlight the fact that this inquiry should learn lessons from what went right as well as from failures. But the Module 4 evidence has shown that even where there were successes, there were shortcomings. And even where things went right this time, there are stark lessons going forward, very stark lessons. And behind many of the perceived successes, there is underlying evidence of a lamentable lack of planning and preparedness and resilience. And whilst it's right to note, still right to note great efforts to save lives from a standing start, history will repeat itself if we do not set those efforts against the reality that the United Kingdom and its 4 nations was so remarkably unready. And next time, a standing start may produce very different results. As we well know, the development of vaccines and therapeutics for the next disease X may well be very different. Nadeem Zahawi likened the UK approach to building a plane whilst flying it. If ever there was an analogy which cautioned, don't do it again, that was it. And similarly, we submit the perspective of Yvonne McNamara from the Traveller Movement, about which you've been reminded only a few minutes ago by Mr. Jacobs, that you can't build an ark after the flood has started. The plane and the ark need to be built now, outside of an emergency. I anticipate all of us will recognise the importance of the evidence of Dame Kate Bingham, underlined by that of the phenomenal Dr. Dix, who played a central role in the initial period of the VTF. Her bottom line has been to caution that as the pandemic eased, the UK, in many respects, relaxed back to where it was in January 2020. And this conclusion rests not only on Kate Bingham and Dr. Dix, but on several other witnesses. Only on Wednesday, Lord Bethell, Minister during the pandemic, gave the following alarming assessment. His words, and I quote, "Frustratingly, I think we're in a worse shape today than we were 5 years ago. The NHS is clearly under a huge amount of pressure in terms of capacity. The workforce are under pressure, and there's been a drop-off in recruitment. International surveillance of viruses is not where it could or should be. In terms of the institutions of resilience, UK HSA, for instance, should be a national agency with heft and resources, and I'm disappointed that it has been denuded in the way it has been. Local resilience forums remain shadow organisations. I could go on," unquote. Kate Bingham reminded us that COVID was the 7th pandemic of this century. Yet there was no UK government vaccine plan for development, manufacture, supply and rollout, and little consideration of vaccines at the DHSC beyond flu. A key initiative which could have made a significant difference, as we heard earlier, was the Vaccine Manufacturing and Innovation Centre, conceived in 2017 to onshore vaccine manufacture and expressly to provide manufacturing capacity during a pandemic. It had not progressed by the onset of the pandemic, despite the allocation of hundreds of millions of pounds of public money. By the time the project was abandoned, it had not contributed a single vaccine dose, with its publicly funded centre sold off to a private US healthcare company and then mothballed. From the evidence, it's unclear how much of the public funding has been recovered, but it's a salutary example of abject governmental failure. We're told the Moderna Innovation and Technology Centre will become operational later this year, more than 5 years from the onset of the pandemic, and we heard about the limitations of that this morning. Kate Bingham told us that there should be no need for task forces. Competent government, she said, should maintain readiness and capabilities for vaccines and therapeutics. She identified not only the complete absence of planning in this area, but the suspicion of industry from within the civil service, a lack of science and technology skills possessed by those recruited via its fast-track graduate entry scheme, and a risk-averse culture as key problems. Better not to try than to fail, lest you be criticised, seemed to be the accepted working practice. And these were views largely echoed by Eddie Gray from the Antiviral Task Force. Kate Bingham brought a wealth of relevant and crucial experience to the VTF, a team of seasoned experts to hit the ground running. However, as she laments, and we heard this morning, that once she'd left, her successor soon followed her out the door because of a lack of support from civil servants, and the industry experts were dispensed with too, which, quote, reflected incredibly badly on the UK. Her words, not mine. She commented that thereafter there has been a concentration on one platform, which is bad for the UK going forward. Contracts with smaller vaccine producers, including Valneva, Novavax, were cancelled, causing losses of jobs in Scotland and Darlington, a move which Kate Bingham described as not only inexplicable, but improper. Again, her word, not mine, and driven by cost-cutting to the detriment of industry relations for the future, a view underlined by Dr. Dix today. The failure to take up the Evusheld cocktail left the UK to be the only Western country not to prophylactically protect its immunosuppressed. This was forthright evidence from two key figures in the vaccine response. Not all of it is accepted by others involved, of course, both regarding Evusheld and the cancelled contracts. But her views and those of Dr. Dix are compelling. She proposes that there should be a vaccine czar, this time my word, not hers, working alongside the responsible minister with similar status and access to the National Security Advisor, and she and Dr. Dix call for the vaccine agency. We endorse the thrust of those proposals. But moreover, we call for a clear published UK government vaccine and therapeutic plan to cover development, resourcing, manufacture, supply and rollout. And we also propose that there should be similar overarching plans in each of the devolved administrations to ensure that there's both full cooperation and proper protection of devolved powers. We fully recognise the importance of planning remaining flexible because the characteristics of the next pandemic and its effects may be very different to this one, but there are also constants and themes which will arise. The need to identify the vulnerable, the imperative to combat the consequences of discrimination, the infrastructure of both supply and delivery of vaccines and drugs, prioritisation, protection of key workers, and so forth. The inquiry's heard a deal of evidence regarding inequalities and different vaccine percentages across different groups. We endorse and follow the submissions made by Mr. Thomas, King's Counsel, earlier, amongst others. The problem should not be seen as hesitancy or one of so-called hard-to-reach communities. The problem is systemic and must be addressed and solved or mitigated systemically. there are two key points to vaccine coverage. The first is safety and efficacy, and the second, access. There's been somewhat complex evidence regarding diversity of clinical trials. Dr. Wakar gave evidence that there has been a historical problem with the lack of diversity in trials. Big Pharma insists that the COVID trials were fully diverse and point to trials elsewhere, which ensured that there were sufficient non-white participants and people with different ethnic groups involved. The expert Professor Prieto Alhambra gave figures which show that participants in the UK AstraZeneca trials were disproportionately white, with the same caveat that diversity was improved by other non-UK trials. Meanwhile, Kate Bingham comments that the Cabinet Office were not prepared to fund a publicity campaign to ensure sufficiently diverse volunteers in the UK, whilst the MHRA opined that the trials were satisfactory in terms of diversity, but there remained work to be done. There are notorious cases of drugs deployed having been tested against other demographics, which have gone catastrophically wrong. Diversity of testing is universally recognised as a necessary precursor to authorisation. It's not only about confidence. For example, a quick Google of open source material reveals a case within the last 30 years regarding the use of a novel drug to treat children in Nigeria by a major pharmaceutical company, despite the fact that it had only been trialled on adults and which resulted in dire consequences. Given the evidence, and particularly from the MHRA, we do not suggest that the COVID trials were unsafe, but we do say this inquiry should focus on the evidence of work to be done, and that should be taken seriously. In our view, there should be a requirement before authorisation that clear evidence of trial diversity must be produced and published. Trial diversity must mean that to the greatest extent possible, the trialists should be representative of the population within which the trial takes place. Where there are barriers to that, and we know there are real barriers, for example, involving pregnant women or those where there are issues of consent, the applicants for authorisation must set out the limitations of their trials. If there was a clear public requirement for a higher standard of diversity before authorisation will be granted, then those designing and operating and resourcing the trials will solve or mitigate issues such as ethnic diversity, which are not intractable. We submit this inquiry should recommend such a public diversity requirement. Requiring diversity for safety and efficacy purposes overlaps with and leads on to the second point of confidence. If UK clinical trials do not reflect the whole community, if individuals cannot see people like us, there will be an inevitable adverse perception by those that are thereby marginalised, irrespective of whether that lack of diversity is mitigated by trials taking place elsewhere. The evidence of experts Professor Evans and Professors Chandler and Kashtan de Bush was that ultimately trust in marginalised communities is a structural and historical issue. But as well as tackling those fundamental whole system problems, confidence can and must be addressed to reduce the coverage gap. This is not done by projecting the problem back on marginalised individuals, by describing them as hesitant or hard to reach. It's done by proper planning, both in terms of a more general strategy to combat health inequalities, but by specific pandemic planning itself. It's well known, as I've touched upon, that there are real adverse prior examples from around the world occurring disproportionately away from the wealthiest nations, and historical memory was acknowledged, amongst others, by Dr. Gillian Richardson, the SRO from Wales. Disparities of coverage can be mitigated by systemic planning to identify the issues ahead of the emergency, working with people and organisations from within those communities before the emergency arrives, ensuring not only that vaccines and drugs are safe and efficacious for all, but ensuring that they're seen to be so with clear public messaging, and planning ahead of time to message and supply those new treatments in ways in which and places appropriate to those communities, ensuring also that intersectional issues are recognised and addressed. including language and literacy barriers. And finally, I turn to evidence from the bereaved themselves. As in other modules, you've heard that evidence before you. It is undeniably powerful. Jean Rossiter was the first Module 4 witness. She and her family lost their son, Peter, an otherwise healthy 39-year-old teacher and key worker. She raises two particular issues. Firstly, prioritisation, and secondly, dosage intervals. As a matter of logic, had Peter been vaccinated earlier, or had his second dose earlier as manufacturer recommended, his chances of contracting and succumbing to COVID would have been exponentially reduced. Although we've heard justifications for prioritisation and dosage intervals, which amounted to a policy to do the greatest good with limited supplies, there are 2 points. Firstly, those limitations of supply might have been much reduced had there been proper planning and resilience in onshore manufacturing. And secondly, there was recognition that some key workers should be prioritised whilst others were not. And there were differences of approach with respect to certain sectors, for example, care home staff in England and in Scotland. It's not hard to understand Jean's distress and frustration at the effect of those decisions, not only her loss. In Jean's statement, not only in the oral evidence she gave, there are accounts of others within the COVID Bereaved Families for Justice group. I'll mention simply two. Winifred Partington, aged 82, died in hospital unvaccinated in March 2021. She'd been in hospital for some months, and despite receiving vaccination letters to her home, and despite the hospital being a vaccination centre, inpatient vaccination did not start until 5 days before she tested positive. The family are understandably distressed and frustrated that she would have been vaccinated if she'd been at home, yet not in hospital, with the additional risks that brought. Sarah Meredith's son Daniel, 7 years old, had complex needs. Sarah campaigned and spoke with MPs and peers to have vulnerable children prioritised for vaccination. Sadly, Daniel contracted COVID shortly after receiving his first vaccine dose too late and died. Each of those cases and more illustrate the real-life consequences of a failure to plan for a pandemic and the real-life consequences of decisions which left particularly vulnerable people unprotected until too late. The families look forward to your recommendations to ensure that next time others do not find themselves in the same position. Thank you very much.
Thank you, Mr. Weatherby. Mr. Wilcock.
Milady, as you know, I represent Northern Ireland COVID Bereaved Families for Justice, along with Ms Mary-Claire McDermott, and I'm instructed by PA Duffy Solicitors. In opening this module, your counsel, Mr Keith, King's Counsel, stated that the evidence you will hear in this module overwhelmingly suggests that the UK COVID-19 vaccines successfully protected the people of the UK against a virus that was killing and liable to kill hundreds of thousands of people. He was right. He was also right to observe that this remarkable achievement was built on the UK's formidable science and clinical research infrastructure, including those who volunteered for vaccine clinical trials. Northern Ireland COVID Bereaved Families for Justice echo the calls of the many witnesses you have heard, urging you to recognise the importance of maintaining and strengthening this infrastructure in peacetime, so to speak, so that the UK Scientific and Biomedical Research Centre receives the funding necessary to ensure that it is sufficiently resourced and robust to continue experimental research of vaccines and therapeutics so that we might be as well prepared as we can be when we are inevitably next at risk to the as yet unknown pathogen X. And my lady, as Mr Weatherby presaged, those who do not learn from history are doomed to repeat it. And in that context, it was incredibly disappointing to those I represent to hear both Lord Bethell and Dr. Dix tell you in different ways that the UK now is in worse shape today, in many ways, in terms of vaccine resilience than it was 5 years ago. And my lady, with those general remarks and making clear that we adopt the general submissions you have heard from Mr. Weatherby, King's Counsel, can I return to some of the evidence you have heard in relation to Northern Ireland, which, given its inevitable reliance on the UK's greater scale, research capacity and purchasing power, related more to rollout than it did to the development and national supply of the COVID vaccines. Although the only evidence the inquiry was able to hear directly during this module about Northern Ireland came from Dr. Naresh Chadha, Northern Ireland's Deputy Chief Medical Officer, we know and make clear to those listening to these remarks that you will also bear in mind the plethora of other written evidence you have received during the course of this module relating to the provision of vaccines and therapeutic medications in the north of Ireland. And they include the extensive witness statement of the ever-present Chief Medical Officer, Professor Sir Michael McBride, and the former head of the Northern Ireland COVID-19 vaccination programme, Dr. Patricia Donnelly. And we accept that there were no easy or straightforward answers to a number of challenges that the rollout of the vaccination programme in Northern Ireland faced. And we also accept that many of these challenges were successfully faced and overcome. Vaccination centres were established and processes were put in place that allowed vaccines to be distributed to these centres, as well as GPs and community pharmacies. You will have noted Dr. Chandler's specific approval during the course of his expert evidence of Northern Ireland's, quote, very novel approach of a twin-track approach whereby different priority groups could either go to the trust or the GP surgery at the same time. That said, the approach we urge upon the inquiry and other core participants from the north of Ireland is not simply to commend or congratulate themselves on the considerable efforts that were undeniably made by those involved in the Northern Irish vaccination programme, but to examine whether the rollout of that programme could have been improved as far as Northern Ireland was concerned, in order to hopefully learn the lessons to stop history repeating itself, and put those involved on the front foot rather than the back foot, when sadly those efforts will again be required in the future. And my lady, this isn't just a topic for academic study. In describing the difficulties caused by the fact that GP practices were initially unable to handle the Pfizer vaccine, Dr. Chadha stated that he did not think that the Northern Irish programme was particularly constrained by that. It was only just a matter of a week or two. Now, of course, we know what he was trying to say and what he meant. But you have heard from our witness, Fiona Clark, that even that short timescale continues to haunt those who lost loved ones who could only have been fully vaccinated outside that short period he described. In his written statement to the inquiry, Dr. Chadha explained that his initial input into the vaccination programme was in the context of Northern Ireland not then having a permanent senior medical officer lead for vaccinations within the Department of Health. You will recall Dr. Dix's evidence to you this morning about the need for someone in government to fully understand vaccines. We suggest that this reasoning might equally be thought to apply to the Northern Ireland Department of Health. In July 2020, the Northern Ireland COVID-19 vaccination programme Oversight Board was established to set the direction and oversee the progress of planning and ultimately the implementation for a future COVID-19 vaccination programme. As the Director General of the Department of Business, Energy and Industrial Strategy, Ms Alexandra Jones, told you, this didn't ensure more than limited Irish involvement in the early phase of the UK vaccine task force at around the same time. Milady will recall that Ms Jones told you that although there were, quote, conversations that were happening within the devolved administrations, we didn't join them up because of the inevitable growing pains of establishing a vaccine task force. And Ms Jones offered this to you as something she would specifically want to learn from in the future. But back to the Oversight Board. Whilst both Dr Chadha and Dr Donnelly were participants in the Oversight Board, it was not until October 2020 that Dr Donnelly was appointed as the head of the vaccination programme to oversee and drive the planning and operation delivery of the programme. And furthermore, in his evidence to you, Dr Chadha stated that even then, he and Dr Donnelly had to work with what he described as, quote, a relatively small core team of people in the department to try to get the vaccination programme up and running. And Dr Chadha told you, and we have seen nothing to indicate the contrary, that notwithstanding this small infrastructure, he and Dr Donnelly really worked quite well together. But the question we asked the inquiry to consider is whether the system might have worked better had it been on the front foot from the outset and not on the back foot because of the lack of a vaccination lead, and the perhaps surprisingly late appointment of Dr Donnelly as head of the vaccination programme many months after it must have been clear that a vaccination programme was inevitably going to be necessary. And perhaps as an example of the Northern Irish Public Health Authority being on the back foot in terms of their vaccination plans in 2020, the inquiry will recall Dr Chadha's uncertainty as to whether Northern Ireland ever had its own public vaccine plan, and his acceptance that given the significance of communication in vaccine delivery, such a written document which is there and available for people to see is, perhaps as an understatement, really important. Dr Chadha also explained that prior to the pandemic, Northern Ireland had no single IT system that captured vaccination data. This necessitated the development of the vaccine management system, which, although operational by early December 2020, required what Dr Chadha described as quite a lot of refinement and development and improvements of its capabilities to ensure timely access to timely and reliable uptake data. Now, Dr Donnelly, in her written statement, I seek to remind you, described the lack of such a system at the beginning of the vaccine programme as, quote, a major drawback. And your ladyship will recall that immediately after Dr Chadha gave evidence, Dr Chancellor described to you how having these systems in place was extremely crucial. And we ask your ladyship to bear those points in mind when considering some of the submissions your ladyship heard earlier on this afternoon from the Department of Health about this system. In relation to data, you heard that Dr Chandler repeat to you that what other witnesses have sadly told you in relation to other modules. We don't have as much access to evaluations on the Northern Ireland devolved administration as we do in relation to the other three. It's a recurring theme. In spite of these data, and we submit therefore transparency limitations, Dr Chadha gave a relatively positive review of the work that Northern Ireland Low Uptake Group were able to do in dealing with low uptakes among identified occupational groups, ethnic minorities and areas of social deprivation in Northern Ireland. You know from your travels that Northern Ireland has some of the most socially deprived areas in the United Kingdom. Plainly, as Professor Sir Chris Whitty told you, bringing data together in this area is vital, but so is transparency, particularly given Dr Caston Dabush's observations to you for the need for alignment of how data is collected and stored if we are going to be able to identify trends and or evaluate success in this area on a UK-wide basis. My lady, before I finish, can I deal with one discrete topic which affects the whole of the UK? My lady has heard evidence in relation to Parliament's vaccine damage payment scheme. It is unfortunate that, as we understand the evidence, Parliament has not revisited the threshold and the amount of the award of this scheme since 2007. It certainly seems to those I represent that Ms Scott from the Vaccine Injury Bereaved UK had a point when she described the scheme as it presently stands as not fit for purpose. And accordingly, we urge you to consider carefully how your ladyship can best, most effectively reflect the similar evidence for the need for reform in this area that you heard from Lord Sharma and other witnesses, notwithstanding the obvious point that plainly the parliamentary origin of the scheme and the fact that it may be thought questions on the extent and detail of it are inevitably political questions involving both Parliament and the payment of public monies. But in conclusion, we say that the three issues of Northern Ireland's relationship and input into UK-wide bodies, the effect of the historical, systemic and structural failings within Northern Ireland's political and health systems, you are all too aware, and the weaknesses of its data collection systems have all featured in previous modules you have dealt with, and I dare say may feature in modules to come. At this stage, in relation to this module, I'm conscious that we will be lodging written submissions at a later stage, which will include suggested recommendations for the future. That is all I now propose to say on behalf of the Northern Ireland COVID-bereaved families for justice. And we're very grateful for the opportunity of addressing you.
Thank you very much indeed, Mr Wilcock. Ms Mitchell, if you'd like to go tonight, I'm very happy to sit till 2:45.
My lady might not be surprised to know that it's not going to take me till 2:45. I present these submissions as instructed by Amar Anwar and Company on behalf of the Scottish COVID bereaved. The Scottish COVID bereaved understand how lucky we are to have this module on vaccines. Our collective experience would look very different had a COVID vaccine not been found. Given we don't know what the next pandemic will be, we can only hope that we can find a vaccine for disease X. But hope isn't necessary, however, to ensure that when the time comes, there are processes and procedures in place to ensure that the vaccines are developed and deployed at a pace to those who require it most first and to the rest of society as soon as possible thereafter. In order for that to be done, there are various recommendations that the Scottish COVID bereaved will make in writing to the Chair. Before then, we wish to make the following 4 points. 1. At the outset of the inquiry, there was discussion about the use of the term vaccine hesitancy, and it was suggested that vaccine scepticism might be a better term. Having listened to the experts, we suggest that the best term is that of vaccine confidence, which people may have to a greater or lesser extent. Some members of the Scottish COVID bereaved, for example, were not confident that they had enough information to make informed decisions about the vaccine, in particular those with pre-existing health conditions or pregnant women. Concern was also expressed about vaccinating younger people. We don't know what disease X will be, but we can be sure that the best inoculation we have against it at present is education. With education and engagement, vaccine confidence may be fostered. In doing so, misinformation and disinformation that abounds in relation to COVID vaccines may be challenged. It is imperative that prior to the next pandemic, as much as possible is done in relation to public health messaging to ensure that the public has confidence in vaccines and the system of dispersal of vaccines in a fair way, which protects the most vulnerable first and the least vulnerable last, to protect us all in the process. 2. A further important issue, a recurring one, is the need to provide data systems. It stands to reason that in order to provide vaccines and therapeutics such as antivirals, pending vaccines to the most vulnerable, we must be able to quickly identify whatever might make them vulnerable to disease X, be it age, gender, race, physical or learning disability, or any other definable data source that we can identify. Data must be harnessed as a valuable vaccine and therapeutic tool. 3. The Chair has remarked on occasion that so many interactions and decisions come down to individual relationships with people rather than governmental structures. We saw that perhaps no more clearly than when Dame Kate Bingham explained how she had navigated the governmental process. Whilst, alas, we cannot ensure that everyone who governs is competent, we can listen to experts like Dame Kate Bingham and Dr Clive Dix, who are, about how best to prepare for the next pandemic. It may come as no surprise that the Scottish COVID bereaved support the idea of a national vaccine agency and having someone in government who understands vaccines. We hear the concerns about cost and independence of government, but we also know that from all the innovation and speedy changes that occurred forced by the necessity of a pandemic, that where there is a public will, there is a political way. 4. In relation to barriers to uptake, in addition to fostering confidence, we will make recommendations about how vaccines and therapeutics might be best delivered in Scotland, bearing in mind its rural and island communities. Perhaps providing a good practical example of public will leading to a political way that I aforementioned, the Chair may be pleased to hear that since the evidence given by Melanie Newdick on behalf of the Scottish COVID bereaved, routine vaccine delivery is to be restored to Highland GPs, trusted and local healthcare providers, following an intervention by the Health Secretary. In conclusion, science can and hopefully will provide effective vaccine come the next pandemic. But vials of vaccines and antivirals will be useless unless they are used. And in order to do so, we must ensure that we have confidence in them and trust in those who provide and administer them. The recommendations of the Scottish COVID bereaved will focus on how to ensure that we are best placed to foster these sentiments in all communities to inoculate us from the next pandemic. These are the submissions on behalf of the Scottish COVID bereaved.
Thank you very much, Ms Richmond. Thank you for telling me about the intervention of the Health Secretary. One good thing has come out of this inquiry so far, so thank you very much.
Indeed, my lady, and I think the Scottish COVID bereaved were delighted that such a practical effect has happened immediately and people may be protected as a result of that in the future.
Thank you. Very well. I shall rise now and return 10 o'clock tomorrow morning, please.